Welcome to Passionate World Talk Radio. Educate, enlighten, entertain.
Hello and welcome to another Wine and Cheese program. Before I introduce my guest, I would like to thank Lillian Caldwell, CEO of Passionate World Talk Radio, and Jeannie White, who is the station manager that does our blogs and posts our show. I would like to remind everyone that is listening that this is not a medical show, and any information that is said, it is our opinions, and not something you should take verbatim. If you hear anything or you're concerned about anything that we say, you should call your physician and talk to them. So today I have a nurse who is a psychiatric nurse. Unbelievable. She has spent 45 years in the psychiatric field out of the 47 years that she is a full-time nurse. Her name is Joan Jensen. She's a registered nurse with a bachelor's degree and a master's. So, hello, Joan. How are you?
Hi, Sheila. I'm well, thank you. How are you?
I am great. It sounds like we're about the same year.
I think so, yeah.
44 years of nursing, and it's one of the best careers I've ever had. I've been all over the place. So, you know that I am the president of Stop Healthcare Violence.
I do.
And I have found that violence in the healthcare system is almost just as much as this pandemic. It seems as though nurses, doctors, all the other healthcare workers get assaulted. And really not too much has been done about it. I've been working on this since, over 10 years. So I'm going to ask you a couple of questions. And the first one is, have you ever been assaulted while working in the psychiatric field?
The first month that I worked in the psychiatric field, I was strangled by a lady in her 70s.
Oh, and now how were you strangled?
Actually, I was, because for the most part, let me just explain, people who work in the psychiatric field, generally speaking, wear street clothes, which I was wearing at the time, and I happened to be a newbie in psych, and I had a very lovely scarf tied around my neck, which she then grabbed the tabs of and pulled me over the half door because I was handing out medication from the med room and had me hanging over the half door by the scarf that was tied around my neck very neatly and in a very fashionable way, and she was not about to let go. So it took probably 4 staff to actually peel her fingers off the scarf, and I have no idea what particularly she thought or saw that caused her to want to strangle me. But it was really something as simple as that was a tactical error on my part because I was new in the field. It's certainly a mantra that I have with people who work in psych, which is don't wear dangly things ever because those can be used as weapons against you, including sometimes we have nurses come in, agency nurses or what have you, they're wearing a stethoscope very neatly around their shoulders, and I make them take them off because they're dangerous.
They are.
Anything is a weapon.
Yes. When I worked in the emergency room, one of our nurses was with a patient. She was behind the curtain. Security had left her, and she's talking, and the conversation was fine, and he just looked over, grabbed the stethoscope, and just tried to strangle her with it. And when she come out, she was so upset. And the coworkers, were busy, and they shrugged their shoulders, rolled their eyes, and said, "Well, you're not strangled,
right?" Yeah, you're not
And
dead. So
I mean, now this is what goes on, and it's like, what do you have to lay dead here? So, did your administration do anything to help with this?
Well, in that particular instance, no, and I will say, because I've worked, again, in various outpatient, inpatient. I had my own private practice at one point in time, although I will say happily I was never assaulted in my practice. But it's never really been something that administration has directly addressed with the exception of one time, and that was probably maybe 3 years ago, when there was a situation where a patient in a very calculated manner assaulted a bunch of staff quite intentionally. When the owners of the facility where I was working met then with the staff in the aftermath of that, that was when they agreed to provide money in the budget for us to have a security person on. Now at that time it was one person per shift, so one for the day shift, one for evenings, one for the night shift, but then they also had 2 days off a week, so there were always days when we weren't covered with security. But that's really the one and only time I can remember that anybody really directly responded to an assault.
Well, at least that is good. Now, do you have security guards where you work now?
Well, we have one gentleman who works the 7 to 3 shift, and we have one who works the 3 to 11 shift. The one person who was doing some night shifts for us left, I don't know, within the last month and hasn't been replaced. So it's, for the most part, it's just the nursing staff, the nurses and the behavioral health assistants. It's really just us. If we have one of the guys on that's doing security, that's great, but that's not something we have every single day of the week, nor do we have it every shift.
Wow. Do you find that the security guards help, or are they hands-off?
No, it's not. From what I've told, I actually was listening to, I think that Dr. Donald had forwarded me the original show that he had done with you, and I had heard you comment about that security had been told to be hands-off. Our security is hands-on, always in psych. It's at the direction of a registered nurse. That's the only person who can call a restraint. Obviously, if someone has to defend themselves, that's a different situation. But they're very hands-on with us when they're there, and when hands-on is required. And as with anybody else who works in healthcare of any kind, the amount of hands-on that happens frequently is a direct correlation to who the staff are who are working and what their approach to the patients is and what their tolerance is for certain shenanigans that go on in the psychiatric unit.
When I was working in the ER, we had a great group of security guards, and one evening they had come down to say that they were sorry they couldn't come down faster when we needed them. He says, I was up in psych because we had a couple of psych floors. And he said, I don't know why the nurses were calling us, because a patient wouldn't take his medicine and we can't even touch the patients. That was the first time I heard that the security guards were hands-off.
Huh.
And so I don't know if somebody doesn't take their medicines now, do you force them, or is it okay? Or is that
depends
individual?
on the circumstances. There are very strict regulations that we have to adhere to in the psychiatric. The Department of Mental Health in the Commonwealth of Massachusetts is a very powerful organization, and they are a force for all things for the patients, which there should be such an organization for them. So if a patient is in the hospital and has not been committed with a Rogers, which is a document that basically says you can make a patient take medication when they don't want to, it's the ultimate. You take them to court. If they're committed, then they're being held on what's called a substituted judgment, which in effect means the judge has decided that their judgment is better than the patient's judgment about what is good for them, and they are substituting their judgment for the patient's, and then there's an agreement between the attorney for the patient and the attorney for the hospital as to what medications are going to be allowed to be used to treat the patient. And then we need a doctor's order, which then says the patient is ordered this, oral medication. If they refuse it, they are to be given this IM medication. At that point, when those orders go in the patient's chart, or if you will, on the computer in the system that we have, the patient can no longer refuse to take medication in terms of their regularly scheduled medications. The only other time when we can medicate a patient against their will is if they represent an imminent danger of harm to self or others. And then it's a medication restraint, and then that's a whole set of like 11 documents that we have to fill out, half of which go to the Department of Mental Health, and they are very carefully scrutinized as to whether or not we actually had a legitimate reason to restrain the patient in that way. So everything that we do in that way is very carefully scrutinized, and we have very strict regulations we have to adhere to.
Yes. I know about the Rogers. That is something that we have fought hard for. And sometimes we've had to go to court, and but it's only to help the patient. It's not to harm the patient in any way.
No, I mean, the vast majority of patients come in and take their medications and get better and go home. You know, it's nothing we ever want to have to do. That's for certain. Right.
Now, in this instance, well, you were new. Were you ever assaulted after that new time?
Oh, my. In 45 years?
In 45 years, yes.
Yeah, I don't have enough fingers and toes for that. I mean, my approach to work has always been that it's a good day if one of the staff or myself is not assaulted. And a lot of it just depends on how many patients there are and what their particular psychiatric issues are. You know, it's just there are a whole lot of factors that contribute to it, but I couldn't even begin to count how many times I've been assaulted by a patient.
Now, would you ever call the police?
I have, and certainly we have in various facilities where I've been working. I mean, it's a more dire circumstance when that has to happen. But absolutely, I mean, there are times when before anybody gets assaulted, but someone has been threatening in such a way that I felt that it wasn't going to be able to be handled by the staff on hand, that we have asked the police to come and give us an assist. Absolutely. Actually, when I started working in the county mental health system in Milwaukee, the sheriff's department was part of the county, and so it was actually the sheriff's department was on the county campus with us. And in that situation, I was always hesitant to call them because when the sheriff rode into town, they basically told you, you know, step aside and we're going to do whatever we're going to do. And much of what I saw happen to the patients was inexcusable. So I rarely called them, and it was only in a dire circumstance. I haven't found that to be the case, particularly with calling the local police in. They'll tend to follow our lead about things, but there have been times when calling in, you know, the police, i.e. the sheriff, was actually worse than trying to handle it ourselves.
Yeah, because it's a whole different ball game to them. Now, I'm going to ask you, I think it's a pretty difficult question. It's one that all of us as nurses that do not work in the psychiatric field, it seems as though a person that has a mental health issue is allowed to assault any of us without being held accountable. And that's, is there something that we should know as medical nurses, emergency room nurses, surgery nurses? Or do you find that true?
Well, I guess I would say that because you other nurses who are not working in a psychiatric setting the way, you know, I do, I think you are particularly much more vulnerable on some levels. Because first of all, it's not necessarily your expectation that you're going to be assaulted, number one. Number two, you're not necessarily surrounded by staff who are trained to handle people who are assaultive in that way. But when you work in a locked psychiatric facility, we're in a very contained environment. When you're working in the emergency room, you don't know what's coming through the door. You're not in a contained setting, nor are you on a medical floor or in a surgical suite or any of those things. And so we have a much different approach to it because it's literally what we do, and everybody's locked in and we're all contained. It's very different for you, I have to imagine, in the setting that you're in when things are not as contained and all hell can break loose. You have all kinds of equipment around and stuff that can be used as weapons against you, or the patients can use it against themselves. None of that stuff exists in our environment because it's all carefully screened out of the environment when you're working in a contained psychiatric environment. As far as patient accountability, many times the patients that I've been assaulted by have just been so psychotic. They had, who knows, I will say years ago, I was working inpatient in the greater Boston area. There was a woman there who was very psychotic, and every day when I came to work, because I was a 3 to 11 charge nurse, she accused me of having sex with her husband in California. And every day I would say to her, you know, that's not true. I'm standing here in Boston right in front of you. She wasn't married to begin with, you know, and she bent my fingers backwards. She tried to pull my fingernails out. I mean, every day I went through this with her. And so did I think that this woman should be somehow prosecuted for that? No. She was just flat out psychotic and had not a clue. She thought that I was literally doing these things. You know, I had a patient who was a Vietnam veteran one time walk up the hall next to one of my staff, have a flashback, grab the guy, smash his head into the wall, and was trying to kill him because he truly felt that he was in a life and death situation. So do I prosecute somebody who, through no fault of his own, has had a wartime, a PTSD flashback, and suddenly felt that the person next to him was a Viet Cong who was trying to blow him up with a landmine? No. Do I think that the person who, over the past 3 years, who legitimately and deliberately followed the pattern of the staff, made a determination about exactly when the best time would be to attack the staff when most of the male staff might be busy or off the unit or something? It's like, do I think that person should be? Absolutely. And in fact, that was something that we did pursue.
Thank you for doing all that, for saying this, because this is how I feel, is that when somebody is psychotic, and we're trained in the emergency room, maybe I wasn't trained enough, like in the CCU or the medical floor, to pick up on things like that. But there are people that will assault just because they can.
Sure.
And we had a woman that hit one of the security guards that happened to be 6'4" with the telephone. Just because he said, you know, she was swearing on the telephone. And so he said, please hang up the telephone.
Mm-hmm.
And it was just one big mess. But it seemed as though at least every other day somebody got assaulted. And we went to court, and the minute there was any type of mental health or something said by the person that we're accusing, the judge would back down.
Mm-hmm.
And
yeah, the person that we went after, actually the case after like a year and a half, whatever, that case was dismissed, even though there were 5 staff, most of them women, and one of them was a psychiatrist, a male psychiatrist working with us who was very badly injured. None of that made a difference. And the thing is, this particular individual was not psychotic, and in sitting outside of the courtroom waiting to go in for the initial hearing, told the security guards that accompanied him to court the whole outlay of exactly what he did and how he did it and why he did it. I mean, he was very, very, very aware of what he did and did it on purpose, and it was still dismissed. So that can be frustrating.
It's actually very frustrating because as a result, your nurses, you know, number one, don't make out reports, incident reports. Risk management doesn't call, and I don't know if there's some reason why risk management, once they get a report saying that they've been assaulted, why they don't respond. At one time, we had a group of healthcare workers, and this is when I was working in the ER, they would go up if they found out one of the nurses on the floor got assaulted, and they would go up and help her with everything. And then that got shut down for whatever reason.
Sure.
And then there was so many small incident reports, but nobody that wasn't us didn't really care. You know, as I said, they'd roll their eyes and they'd shrug their shoulders. And one instance, I had mentioned earlier about this nurse that worked in a psychiatric ward. The patient had picked her up. She had a little bit of a thing, picked her up and threw her across the room. And she stopped and slid down. And I was assigned to take care of her. And she said to me, the only thing I'm afraid of is my husband is going to come in, and that's going to be the end of my job. And I said, well, why would that be? She says, I'm a breast cancer survivor, and nobody is going to kill me with working. And she was really, really upset. Her husband apparently was never called, so he never showed up. And I've thought about her ever since because she loved psychiatric nursing, and there has to be a special love for that. But now...
Oh, I think so. It's not for everybody, that's for sure.
No, not at all. In the emergency room, we used to have the best team come in. Are you familiar with that term?
Yes, I know who the best team is, absolutely.
And we had some really good best team members, and they would help us because being an emergency room nurse doesn't make me a psych nurse at all. I can tell when I can get afraid. I know when the back of my neck, the hairs can stand up, and I know when somebody is psychotic, and I'm trained to stay away and all that. However, I saw such an influx of patients coming in, and they wanted to get into a psych place. And if it wasn't for the best team, the psychiatric places would have been so full because these are folks that, you know, they were drug addicts and they just wanted a place to stay for a little while. They had their stash with them. And how do you, after 45 years, can you spot somebody that's there just because they need a bed for maybe a few days?
Well, sure. I mean, one of the things that you notice over time is the pattern of when that particular population starts to show up. Our referrals usually go down at the beginning of the month when the checks come out. And then as we get toward the middle of the month and they've used up all their money because of their addiction, then, and especially when it gets cold, then the referrals for those sorts of patients who have substance abuse issues begin to go up. They certainly know, word is always out on the street, you know, if you truly need to get in someplace or want to get in someplace, you just have to use the S word is what we call it. If you say you're suicidal, they won't let you out and they'll find you a placement. And, of course, it's not unheard of then for them to come or get into a psychiatric facility and then demand to be let out because I'm not suicidal, I just said it to get in which case, well, if you want to get out, why did you come in? And sometimes, you know, people can be very desperate. It's like, I don't like this life anymore. I don't want to be this way. I want help. I want to get someplace. And they genuinely mean it in that moment in time. But then when they're faced with facing life drug-free and the psychiatric pain, psychological issues that come along with that and having to deal with their anxiety and face their issues or whatever, they get afraid. And they'd rather use. You know, then all of a sudden being clean and sober and trying to live your life straight up doesn't look so glorious anymore, and then they're angry and they want to get out because they just want to go out and use. It's a vicious cycle that they're locked in, which can be a real pain sometimes for everybody in the healthcare field because it very much feels like it's a revolving door sometimes. But sure, do they come in sometimes because they're homeless and they just don't want to be out on the street or they don't want to be in a shelter or they can't get into a shelter? Yeah, sure, that happens.
I had, when I was working in a different area, I had the secretary after she knew I did a lot of detox. And as I said earlier, I've had a great career, and I worked in the addiction field for years. And this secretary happened to know, and she says, Sheila, can you get my son a bed? And I was kind of surprised because I've been asked a lot of questions, but not. And I says, well, what do you mean? And she says, well, I asked him to leave. I can't put up with him anymore. Now he wants to get into a detox or a psych ward. Can you arrange that for him? I says, well, I wasn't even in a general hospital, really. And I said to her, I don't think so. And she says, well, that's all right. Thanks anyhow. He'll make sure that he gets in because he really can do it. And so sure enough, he got himself a bed, and he comes out, he overdoses and dies.
It's not uncommon. Sadly, it's not uncommon.
It's really, really. I was just so. I mean, I was so saddened by the fact that this is what happens, and it's happening more and more and more in the addiction field.
Sure. Well, I think part of what has also happened is because as state budgets and federal monies go away for treatment of people with all kinds of mental health issues, substance abuse, of course, being one of them, their brilliant idea when they deinstitutionalized everybody and got rid of facilities, some of the larger state facilities that basically became these people's homes. And the plan was that we're going to care for them in the community, but the dollars for that community care keep drying up. And the thing they forgot to notice about people with mental health issues is most of them don't believe they have a mental health problem, and they don't feel like they need any community follow-up, and they don't want to take these medications. And so the notion that they're going to maintain them in the community, I mean, yes, they have the PAC team and they have BEST teams. They have all these people out there trying to help them, but if they go underground, even they can't find them sometimes.
Right.
And a lot of them, many of the nurses that I work with and have worked with also work in home health care. Sometimes they're per diem with us, sometimes they're per diem with the home health care agencies or whatever, but, some of their clients go missing. They go underground, and, everybody's calling them and saying, well, where is so-and-so? And they're like, I don't know. They drive around all over the city that the people live in trying to locate them. And when they don't want to be found, they're really good at going underground. And,
yes.
They don't want to take medication. They don't want to be in the hospital. Some of the addicts, don't want to be found. They just want to do their thing. And, of course, particularly with people with addictions issues, you can't force sobriety on somebody. They have to want it because it's hard work.
It is hard work.
People do interventions with addicts all the time and put them in facilities and pay tons of money for them to go and get care and treatment. But if they're not there yet in their own mind, if they're not ready, they're not ready, and it's not going to work.
I was with a nurse one day, and she was telling me about her nephew. And her nephew was in a pretty expensive detox. And he'd been there for, I think she said 2 months, which I thought was a very nice long time, and that would help him. And she says, I'm really, really concerned because my brother went to visit, and he said to my brother, I know you all want me to be sober, but as soon as I get out of here, I'm not going to be sober.
It's the power of addiction. It's like trying to get people to quit smoking.
And he also died. And the mother is just beside, she just couldn't handle it. And
because then families feel like they failed, and when the families take on the responsibility for that and feel as though they failed their loved one, that can be really difficult to help them see that it wasn't them, it was the person themselves. It's hard for families.
It is. And what do you think would be a good thing for these families? I mean, there's AA out there, there's Al-Anon, there's
and there's Narcotics Anonymous and all. Everybody's anonymous, and they have Alateen for kids who have either family members, parents, siblings, whatever, who are using. And I mean, that helps them to gain a perspective on who's really responsible for what's going on. I'm not sure that it necessarily solves the problem of how sad and awful you feel when you have a family member who goes to that place and ends up dying as a result of it. I think the guilt, especially for parents, can sometimes be very difficult. Sometimes siblings will feel like they knew about their sibling doing substances. I should have told somebody. I should have done something. There's a whole lot of people shooting on themselves, as we call it. And it's very difficult to try to get people to come to a place of understanding it wasn't their fault.
Right, it is, because a lot of mothers and fathers are suffering because they couldn't help their child,
Yeah.
and that's
Sure.
That's very sad. One other time, because I was working in addictions, some of the nurses would talk to me about it, and there was one of the nurses told me her daughter was having some issues, and we talked about Dr. Bob and Bill Wilson, and so I said, she gets involved with AA and all that, and so she says, oh, okay. So she's telling me how about she's going to AA, and she's not sure about this. She says, she's really getting involved with AA. And I said, well, that's good. And she said, are you sure it's not a cult? The other day, she said to me, I just want you to know my daughter has had 19 years sobriety.
There you go.
That is amazing. She's married, has 2 kids, and she's still a sponsor in AA.
Sure.
And
anybody who's worth their salt that works in AA will tell you, if you ask them how many years have you been sober, they'll say, I only have today.
That's right. That's right. That's very true, because you never know who's going to hand you something or slip you a drink.
I've had people have life crises happen. They come in the hospital. I was sober for 22 years and I relapsed. And it's just like, okay, well, 22 years is a good long time. Hold on to that thought. Clean yourself up, start again.
Right. It's hard. It really is hard. Now, Joan, what do you think about this? Do you think that the violence is increasing?
I think that, it's really hard to say when you work in an inpatient psych facility. The violence has always been there.
True. Yeah.
I think the way that I look at the culture at large that we live in now, because there was a time when doctors were revered, almost godlike, and nurses were like at the right hand of God, and we were very, sacred and special and all that stuff. And I see that culturally speaking, across the country and maybe across the world, I don't know, it's like there is less of that holding up of doctors and nurses as the sort of sacred cows or special people that we were once treated as. And so I think that because we are seen more as just ordinary working people, that changes the mindset sometimes of people in their interactions with us. They don't really see us as being any different than any other person. Not that we ever were, but you understand there was always this sort of like, oh my God, he's a doctor. It's like, well, and as I said, believe me, I know this for a fact because I grew up in a family full of doctors. And they were always held in such high esteem in the community and all that stuff. But more and more, I think as we become humanized to people, and sort of like fall off of our pedestals a little bit, sometimes as a result of our own stupid behaviors, because doctors and nurses sometimes act out and do stupid things that just make us no different than anybody else because we have life tragedies or what have you. I don't think that people think it's all that big of a deal anymore, and not in terms of those of us in healthcare, but I think it's the way that we're perceived by the culture at large that has changed dramatically. And I think that that's contributing to it. Although I have to say, I just see violence all over the place happening more and more, everybody against everybody. I don't know when the last time is that I ever went from a 24-hour period without hearing there was some shooting here, there, or somewhere. I don't know. It seems like it's just pervasive throughout our culture anyway. And certainly we are falling victim to that.
I certainly do agree with you. I think it's getting worse. And the fact that when now with the pandemic, there's no visitors in the ER, we used to get assaulted by, if it wasn't the patient's family would assault us, or even the patient's friend. If we got an overdose, all of a sudden this person would have relatives, and they would come in and then be whispering. Well, they're not whispering, wake up and, get better. They're whispering, where is it?
Yeah, exactly.
It's just so sad. Well, I certainly appreciate you coming on, but is there anything else you'd like to say about violence?
Well, I do think that there are certain circumstances in which people should be held accountable, regardless of the fact that they were in a mental health facility. I don't think that gives everyone a 100% across the board pass. And I think that the legal system needs to take a look at ways in which you can discriminate, like who truly had not a clue what they were doing, and who was capable of refraining from that behavior and chose to do it anyway. You have to be blind not to be able to pick out the differences, but, at this point, it seems as though the legal system is still like giving a broad brush to, and to anybody who's in a mental health facility or has a mental health diagnosis, by definition, is not in control of what they're doing, and I don't subscribe to that. I think there needs to be a fine-tuning of the systems so that there are people who can be and should be held accountable for their behavior, are held accountable for their behavior.
I totally agree with you. And it seems as though when people aren't held accountable, then it's a put down to them. That they know what they're doing, and they know they can get away with it. So why not get away with it? But that doesn't make that person any better.
No, and I'm not sure that I necessarily can always say I understand what the person's motivation might be. Sometimes they feel that they've been mistreated and disrespected in the system, and I can't say 100% across the board that doesn't happen in healthcare. Sometimes healthcare workers they are disrespectful to their patients, and sometimes it's because you're working on your last nerve, and that's all you got. But when I worked in a different system, we used to have to go for our best practice days of, sort of like reorientation or whatever, and they used to address compassion fatigue as something that afflicts people who work in healthcare, and certainly pandemic or not, we all suffer from compassion fatigue sometimes. It's like, I just don't feel like putting up with your crap. It's sometimes that's just how you feel at the moment. And it's like, and when those things break through and we don't manage to keep a lid on that, then we are responsible for setting off the dynamic that then results in not very good things happening. Sometimes it's violence. Sometimes it's just them calling you every unkind name in the book they can think of. But we always, we cannot ever separate ourselves from the role that we play in the violence that happens around us sometimes. And it's hard to always be aware of it, but that's one of the reasons why when we have a restraint, we have a post-restraint process where we step back and say, okay, what could we have done differently here? Where did we mess up? Was there something we missed? Was there a clue that we didn't see?
And that can happen.
Yeah. And when the staff is out straight, the units are crazy, and everybody's acting up all over the place, and food trays are flying and all kinds of things. It's like, and then somebody comes up and makes what is truly an unreasonable demand, and you just don't have that moment of patience to just address it without not making a terse remark, then all hell breaks loose even more, because, you might not have gotten just the exact soothing words out of your head at that moment in time, and that can just spiral out of control. And it's never anybody's intention, but it certainly can be the end result.
Right. Well, Nurse Joan Jensen, thank you for coming on the show and sharing all your information.
Anytime.
I believe mental health is a huge problem, and with the pandemic, that doesn't help at all. I mean, even people that have never been diagnosed with a mental health issue are having mental health issues now because of lack of sociability, all of these things. People are afraid to go out. They're afraid to do anything.
I think the isolation has been devastating for a lot of people.
It has.
Of all
Especially,
ages.
Again, I just want to thank Lillian Caldwell and Jeannie White for letting us tell our stories on Passionate World Talk Radio. So thank you again, Joan.
Thank you, Sharon,
hopefully you'll be able to come on the show again.
Sure. Anytime. Thank you for your time.
Thank you for listening to Passionate World Talk Radio. You can listen to this program all over again by going over to https://passionateworldtalkradio.com. You can also hear it on Spotify, Spreaker, Amazon ALEXA, AMFM247.com every Tuesday evening between 8 and 9 p.m. YouTube, Facebook, Facebook Live, LinkedIn, and all the other podcast directories one can find on the Internet.